Public health, to me, is looking at the larger picture, not just of us as individuals or members of families or communities, but larger community, global community. When we talk about negative effects that impact society, we have a system in place to track and monitor negative health outcomes. For example, we've been able to make tremendous strides in things like people wearing seatbelts, driving cars, and wearing helmets when they're riding bikes or skateboarding, and therefore we've reduced head injuries. We can look more recently at something like the COVID pandemic. And one of the most important things about what public health is designed to do is detect when something is going seriously wrong, try to identify if there are things that we can do about that, and then educate the public. And in order to educate the public about a health consequence or a health risk, we need to have good, reliable sources of information. When I think about the history of the opioid crisis and fentanyl in particular, overdose deaths have increased dramatically. And when you look on a graph at the number of deaths year over year, it has gone up steadily for nearly 25 years. That is the curve that we talk about flattening. In the case of the pandemic, it was the number of deaths or cases due to COVID infection. And when people talk about, quote, flattening the curve, the whole idea is, can we get in place measures that then allow us to reverse the trajectory of something bad that is increasing so that it then decreases over time? We at least want it to plateau. In the case of COVID, that took years, and the lasting effects of not flattening the curve fast enough were more likely that the impact of the pandemic was worse than it could have been, especially if we had agreed on approaches as to how to help. In this case, when we're trying to flatten the curve around opioid overdose deaths and fentanyl use, we're talking about trying to identify where are the hot spots for these types of drugs. For example, are they coming across the border? Are they being manufactured here in the United States of America? Who is at risk? We know primarily for substance use that people with lower educational backgrounds and with lower socioeconomic status and poverty are at higher risk, in addition to having family histories of substance use. What we are seeing now is that we have identified that we are on a negative trend, and the idea is one way we could help flatten that curve is to get more people into treatment. We do know that treatment works, including for opioid use disorder, and often it requires approaches that may not be in line with the traditional abstinence-only model. One of the hallmarks of public health at this point in time is the whole idea of harm reduction. Harm reduction is simply trying to minimize the negative consequences of a behavior that might be causing, for example, negative health consequences. If someone is using opioids and injecting them intravenously, they are exposing themselves to all manner of infectious and medical conditions that go beyond the substance use disorder. That may lead to them having to go to the emergency room, to be admitted to in the hospital. And in those cases, one of the things we talk about with harm reduction is, can we move a person who's using intravenous opioids into treatment and, first of all, reduce the most risky behavior, which is injecting them IV. If they are going to continue, one of the ways we try to reduce the harm is by offering things like syringe exchange programs. What these do is acknowledge that the person who has this disorder is going to continue using the substance to their negative harm. In the case of at least trying to make sure if they're going to inject drugs, they use clean needles, that is the point of harm reduction. The hope would be that they would then move into active treatment, where they would be involved in counseling, where they would see medical providers, and where they might be placed on something that would be a medication-assisted treatment for opioid use disorder. These treatments include methadone since about 1965, and methadone, unfortunately, is one of the most stigmatized medications that we have for treating a disorder in the world. The benefit of treating someone, for example, with methadone or buprenorphine, which is another medication to assist with harm reduction, is that they are engaged in treatment. Rather than being out on their own or with other frequent users, they now have some accountability. They have a counselor. They need to come in every day for medications. They have to provide urine specimens for toxicology testing to see if they are continuing to use illicit drugs. And all of that, what we know is that people who do engage in treatment for opioid use disorder can get better. In order to flatten the curve around opioid overdose deaths, we need to get more people into treatment, and that often involves a very stepwise process. First of all, treating them as people, understanding that the source of substance use disorder is far more than just saying this is a problem among homeless addicts. What we're talking about is a problem that affects teenagers in the suburbs of America. We're talking about families with homes and jobs and lives that become devastated by the impact of opioid use disorder, in particular fentanyl. Another way that we're trying to flatten the curve, especially around opioid use overdose deaths, is that we are trying to get treatment to people when they need it and where they are. In order to meet them where they are, we have to understand that this is a larger community problem. One of the areas that we're focusing on is, for example, when someone overdoses on fentanyl, for example, our hope is that people understand that there is a way to reverse that overdose by administering a medication called Narcan or naloxone, which has been available for a long time. You can either inject it into the muscle or you can spray it up the nose, and it can save the person's life who has overdosed. One of the challenges at that point is the medication then immediately puts them into opioid withdrawal. Opioid withdrawal is extremely uncomfortable and distressing for someone who has opioid use disorder. They feel terrible. The body aches and shakes, there's cramps. The whole reason it was called quitting cold turkey is that they have goose flesh on the skin, nausea, vomiting, diarrhea. And the first thing they want to do after having been resuscitated from almost dying is go get more opioids. This is counterintuitive, but it's their body in acute withdrawal telling them. So often they will even refuse transportation to the emergency room by an ambulance. For one thing, they don't want to bear the cost, potentially, of being transported. But another is that they're not ready at that moment to go into the medical treatment facility. Perhaps they've had negative experiences already with prior overdoses and have been in the emergency department and been treated with the stigma that comes along with it. Even the most caring and compassionate healthcare providers have been known to become judgmental and to not treat people with the dignity and respect that they need, especially when they're coming in a situation of a self-inflicted overdose. In the case of what we're trying to do to help that, we are now empowering our paramedics and emergency medical technicians to be able, once a person has had their Narcan administered and they are now resuscitated and awake, we want to offer them potential treatment on the spot. In that moment, when they have almost died, it is our hope that if we can offer them in that moment a medication to help with the opioid withdrawals, such as buprenorphine, and on the other end, we have arranged for treatment providers to reserve spots for people to then have an intake appointment within 24 hours. And then beyond that, we even have peer support counselors who are typically people who have a history of opioid use disorder themselves, but they have now recovered. They're on the road to health, and what they want to do is they want to give back and help others. What they are doing is providing support, including transportation, to get people to an appointment so that they can immediately begin medication-assisted treatment for opioid use disorder rather than be lost to follow-up. What we know is if that person refuses transportation or refuses care, they're very likely to go seek out even more fentanyl, more opioids, and continue injecting or smoking, and they're very much still at high risk for death. So how do people end up in a situation where they have severe opioid use disorder? They're injecting IV drugs, something that's unimaginable for a lot of people. It's a variety of ways. One of them is that they may be born into an environment where there may be a family risk of substance use. They may have even been exposed to substances in utero while the mother was pregnant with them. What that causes is a change in the opportunity for the brain to develop normally. When you think about a healthy brain in an infant, a young child, and an adolescent, they need things like nutrition. They need sleep. They need love and caring and support. But if you're born into an environment where the whole family has already been devastated by substance use disorder, we don't really see that as a choice. This is a difficult concept for people to understand because they often think of addiction as something that people choose to do. That is simply not the case. They may have chosen to experiment, but what happens in the long run is that as someone's behavior starts to go down the path of using substances more and more, we know now through modern science that the brain actually gets hijacked. The part of the brain that works to inhibit those impulsive behaviors gets less and less influential over the part of the brain that is driving for some kind of pleasure or satisfaction. What a lot of people don't know is that over time with opioid use disorder, all they are trying to do is feel better and keep from feeling sick. They no longer get the euphoria or the high that they got early on. And at this point, it's their body and their mind telling them, I need to get more of this substance or I'm going to suffer physically, mentally, and then try to deal with the health consequences that come from this out of control behavior. In addition, there are legal consequences. So when someone, for example, has been using substances to the point where their brain has been hijacked and they're losing their free will, what we know now from the National Institute on Drug Abuse, that there are underlying brain mechanisms that lead to that loss of free will, loss of choice, or loss of what we call cognitive and volitional control. We believe then that the seeking of this substance and the using of this substance has become so automatic that it's extremely difficult to get that to break that pattern. It is extremely difficult to break that pattern. What evidence is showing us now is that it almost always requires a medication to actually break the cycle, especially around opioid use disorder. The traditional abstinence-only models work for some substances, in particular alcohol. The difference with opioids is that because of these changes in the brain structure and function, when you remove this substance, the suffering drives that person to seek out that substance again. So the relapse rate for opioids is over 90%. This includes people who have been in traditional substance use treatment where they have lived in a residential treatment facility for, let's say, 30 days. They've participated in group and individual therapy sessions. They are learning skills about how to communicate and try to address their addiction. But what happens with opioids is many times after they leave a program like this, they almost immediately relapse. And one of the biggest dangers about that is that they then may take the same amount of fentanyl, for example. They may inject it the same way, for example, as they did before treatment, only now the changes in the brain have left them susceptible to overdose death. Other examples include being in jail or prison where you are not using opioids, and yes, at that time you would say that you are abstaining from opioid use disorder. you're abstaining from opioid use. The problem is that in that controlled environment, once the person is out of that and has access, this automatic part of their brain that has been changed, altered, and drives them to seek it out, they will seek it out, and we know that that is a time where they often die. What we need to do for public health, what we need to do for the sake of public health, is to engage those who need help wherever they are, which often includes in correctional facilities, or during the process of, say, being arrested for a crime that may or may not have anything to do with the substance use. But if they are booked into jail, they now have a problem. Are we addressing the need not just to treat them in the moment, but also to connect them with resources in the community so that when the time comes for them to be released from incarceration, they're not just walking out into a high-risk situation. We are actually creating a warm handoff or a clinical pathway for them to remain in treatment, which often takes many years when we're talking about opioid use disorder. Another common pathway to opioid use disorder is that a person has a medical problem or an injury or an accident. For example, a motor vehicle accident. Let's take someone who's never had issues with substance use and does not have a family history or other predisposing risk factors, but now they have a very serious and painful medical condition. Historically, we were quick as a medical community to prescribe pain medications because we want to alleviate suffering. That is what we are. We are healers. We don't want to see people suffer. However, what happened was that the medications that we were prescribing for pain were not monitored carefully enough, including talking about potential benefits that these medications had that they really didn't have, and underestimating the risks that were associated with medications. A very good example is the medication OxyContin, which is a controlled release form of oxycodone. Around 2007 and 2008, it became very apparent that the use of OxyContin was getting out of control. At the same time, it was being promoted by the manufacturers and by some elements of the pharmaceutical industry to the detriment of people, and the fact that they then saw increased rates of opioid use disorder directly related to the over-prescribing and under-monitoring of pain medications. What then happened was the decision was made, when this risk was identified, to try to flatten the curve, especially around opioid overdose deaths that have to do with prescribed medications like OxyContin. One of the first regulatory changes that took place was OxyContin, the formulation was changed so that if you tried to grind it up and inject it or snort it or smoke it, it didn't work. It gummed up, and all of the prior uses and ways people were finding to get the OxyContin into their system for the high was now gone. And not only that, the availability of OxyContin was curtailed, so that it was much more difficult to find and very expensive. As a result of these regulatory changes, and this also included clinical guidelines for the prescribing of narcotic pain medications and better monitoring, including better communication between the prescriber of the medication, the pharmacy, and any ongoing other medical providers, to keep people focused on their care and to not doctor shop or not pharmacy shop. And to that effect, we also implemented what's called the Prescription Drug Monitoring Program. This is a particular benefit to someone who is prescribing pain medications or methadone or buprenorphine, because we can actually look into a prescription database and see if a patient has obtained medications that fall into this category from another provider, from another pharmacy, or from somewhere else, even outside the state in many cases. These regulatory changes actually did flatten the curve around 2009 and 2010, such that we saw fewer numbers of deaths from prescribed opioids. The problem is that because of this restriction of access to the prescribed medication opioids, the illicit use of heroin and then fentanyl increased dramatically. So where we saw a flattening of the curve around the prescribed opioid medication deaths, we saw a spike in the number of illicit heroin deaths, fentanyl deaths, and so therefore it was simply a shifting because of the nature, the powerful attraction of the opioids and the severity of the withdrawal, that they went from prescribed medications to the street and obtained those substances with the negative consequences that go along with that. I have been in this business for many years. In fact, I first got my MD in 1990. I trained as a psychiatrist and completed that in 1997. I've seen these trends over many years, and we have not done enough to address this problem. It's not simply frustrating when I look at all of the factors and the things that we could control, such as providing more community outreach, engagement, education, resources, and the kinds of things that can help people understand the dangers and the negative consequences so that they can avoid them, especially for parents with adolescent children, grandparents who have always kept pain medications in their medicine cabinet, but these days we talk about the kids bypassing the liquor cabinet for the medicine cabinet. We need to be sure that people are aware that this is a risk, and that where we used to keep medications because, well, we might need it again someday, or who knows, we're just thrifty and we don't want to throw anything away. In this situation, that could be deadly. And so what we need is an organized public health campaign where we all agree on the statistics and the data, and we all understand that this is a problem that we can help. This is not simply a matter of someone having a bad character or an inability to pull themselves up by their bootstraps, so to speak. These are addictive behaviors that have taken root and that affect all of us. What I would like to see us do is to pay attention to the fact that if we create a way for people to get treatment and we offer them treatment, they will accept it. We know that. We will ask people who come to the syringe exchange program, if there was a treatment slot available for you right now to get on buprenorphine or methadone, would you accept it? And over half say yes. We need to be able to intervene at that moment we need to intervene at that moment in order to do more, not just to flatten this curve, but to create a better quality of life for all of us, not just the individual, but for those people who are around them, whether it's in the schools, in the workplace, in families, places of worship, spiritual centers. If we actually engaged all of our community resources and put them towards this problem by not just judging people who have an opioid use disorder in particular, not just lumping them into a category or stereotyping them, but in fact looking at them and seeing them for who they are and for what they could become, what their potential could be, asking questions with curiosity and caring and compassion rather than saying, we need to build more prisons and just get them off the street and out of my sight. If you hear me say one thing, it is that we cannot incarcerate away addiction. As a physician, I have taken an oath, first of all, to do no harm to my patients, but through training and through my education, I also understand that I am in a position to advocate not just for my own patients, but for our community as a whole. I have a moral and ethical obligation to my patients, but also to those around me. In the situation where we know that there is a problem and we have seen the consequences, we need to come together in order to honor this obligation as a community to support our fellow people. We are citizens of the same country. We are global citizens of the same planet. What I would like to believe is that the vast majority of people are good, and they care about others, and they understand when someone is in distress. When we talk about deaths of despair, this includes things like death by suicide, death by accidental overdose. And how do we know if someone intentionally overdosed by taking more than they usually do, or if it was an accidental death from taking the usual dose, but just not caring whether one lived or died? The only way death is called a suicide if someone leaves a note or if there's a witness. And many of these deaths by fentanyl overdose or other opioid overdose or polysubstance drug-related deaths, there is no note, there is no clear indication of whether that person wanted to live or die. We do know, though, by their behaviors that they're in distress and that they're in a state of despair. I don't know how people can turn away from that and say, that's not my problem. The way I see that is, it's all of our problem. And if we do work together and combine resources, and I'm not talking about just the medical community, I'm talking about the business community, I'm talking about the law enforcement community, I'm talking about the judicial system. I'm fortunate to be working in an initiative right now where we are training judges, psychiatrists and judge teams together are training judges and the whole court about how we could potentially see that this situation, this legal problem, however it came to be, really at its core is because of a substance use disorder. In that case, is the answer really to charge someone and to incarcerate them? Or is it to try to divert them from that path and into perhaps some kind of mental health or substance use court where these problems can be tackled by engaging the person in a conversation and engaging them in treatment and an intake process to care for them, rather than simply to try to do the short-term thing, which has led to overcrowded jails, overcrowded prisons, and I have been involved personally in situations where it has led to in-custody deaths related to primarily substance use disorder, where the person would have been better served and had a better outcome if they were in a care setting, whether it's a residential setting or the hospital. We need to be placing those solutions in front of those with the problems so that we can agree. If we invest up front, we will have savings, and not just monetary savings, but in terms of quality of life for everyone living in our community. One of the reasons I focus on the stigma associated not just with the substance use disorder itself, but also on the treatment, is it has led to situations where it's traditional, not in my backyard. There are a lot of arguments about where to place clinics that serve those with substance use and mental health disorders. If we do this right, we now have the ability to engage people in treatment where not only does it not overflow into the surrounding environment, but it actually helps people get an education. It helps them get housing back. It helps them reconnect with their families and friends, because many of them have burned bridges that they thought were beyond repair. But what I have witnessed in my career is that those who do get on treatment, especially for opioid use disorder, they do build their lives back. And we can help provide the opportunity for them to become a citizen, a contributing citizen again of society, and not someone who just goes from one resource to the other, from the emergency department to the hospital to the jail to the street. Although some of the regulatory barriers have been improved, and one of the things that the COVID pandemic did was to allow some loosening of the regulations around the treatment settings for methadone or for buprenorphine. And what we saw was that there was no increase in negative circumstances. Nobody was demonstrating that by giving people more independence and ability to take their medications home with them that this was causing a negative trajectory. In fact, we believe that even more people may have engaged in treatment, and as a result, they are able to now function and they are able to help others by giving back to a community that before they really were only taking from. One of the barriers that has been lessened to some extent is a mobile clinic, a way to take vans and to take cars and to go out to where people are, and instead of expecting them to take a bus to an appointment which might require 3 transfers, we can go to them. We can set up mobile healthcare clinics that integrate primary care with preventive screening and mental health and substance use treatment on the spot. If we continue to do that, I feel very confident that we're going to see trends not just in greater engagement of people in treatment, but as a result, we will see a reduction in the use of the other resources, medical, emergency, law enforcement resources, and instead we can have people getting back to leading productive lives where they have their own jobs, they pay taxes, they contribute, and they support themselves and others. The difference between saying I'm going to be a healer and the moral and ethical obligations that we're talking about is not just on those of us who've taken oaths to care for patients in our society. It's also for those who simply understand that altruism and kindness and giving back to the people around us creates a positive benefit for ourselves. Not only are we helping others, we are giving ourselves a better opportunity for our own improved mental health, our own improved sense of spirituality, and a place in the world with meaning by helping people in these circumstances.